First of all, I want to say welcome. Thank you so much for being here and being willing to sit down with me so I can ask you all these questions. First, I would love if you could introduce yourself to the people out on the internet and tell us a little bit about what you do.
I'm Averee Chifamba. I am the owner and primary midwife right now at Saddlepeak Birth. And we run a concierge home birth practice here in Bozeman and surrounding areas. We will go up to 2 hours away to bless families with home birth in the area. So it's not just Bozeman Central that we work with. And then we also do craniosacral fascial therapy coupled with lactation for moms postpartum. So that's not just strictly home birth clients that we do that for. We'll do that across the board for whoever needs it. So we see a lot of hospital moms, a lot of moms that are seeing other midwives or the birth center, that are needing help with lactation postpartum. So we see them as well in that regard. And then we do everything birth. We do placenta encapsulation if you need it. We have a whole store of stuff that we make as far as like herbal products, but primarily we focus on home birth in the Gallatin Valley.
Fantastic. Thank you. Can you tell us what drew you to midwifery as a calling?
It's really interesting because when you asked me to do this, I was sitting and I was pondering this over the last week, and I was like, what drew me to midwifery? I guess I've never been asked that specific question yet. And as I sat pondering, I was like, when I started my journey, I always just assumed I would be in medicine. Like I was just always told that as a kid growing up, like you love kids and you're going to be a doctor one day. And I guess I just never questioned that. And so when I started going to MSU, I was like, well, I'm going to be a doctor. That's what I'm going to do, is like go into women's health and be a doctor. And and then when it came to MCAT time, I was sitting there and I'm like, this doesn't fit me, right? And so I was pondering, I was like, what is it really that brought me to midwifery? Because when my best friend was sitting there in worship practice and was like, you would be a great midwife. And I was like, wow, I don't even really know what they do. I better check this out. As I started on my journey of midwifery, and I sat here pondering this the other day, I thought back to the first home birth that I was a part of, which was hers, my best friend's. And I was sitting there pondering her birth. And I was like, what was it that drew me to midwifery? Because it was it was a standard, beautiful first time birth, right? But I was like, it wasn't necessarily the medical piece per se, or the baby coming out, or the newborn. Like those are not the pieces that stood out to me. Honest to Pete, like I was sitting there and I go, wow, it was the empowerment of the woman to birth the way that she wanted to birth, to have the community of women around the family that was helping her birth, and that powerful piece of handing that healthcare back to her. It was very relational. And I was like, was it really relationship that brought me to midwifery? Like that's the piece for me that like it finally dawned on me that I was like, holy cow, like we were able to love her as deeply as we wanted to love. There was nobody that told us it was wrong or that it was too much. So we could love her however she needed to be loved, find her in the place that she was and meet her there, and then hand her back these pieces to where she was so empowered to take the next step as a mom. Like I truly believe it was a calling that fell on me that day, because I can't even put my finger on what it was when you asked me that question. It was just like, it was this gorgeous set of things that collided. And I was like, that's me. That's my heart in a job. And so from that day forward, I was like, the midwife that I was watching help this birth, she goes, you caught the birth bug. And I was like, I did catch the birth bug. And I think it was really the birth fire, where it was like, and it's the home birth fire, it's the midwifery fire, I think, that I caught. And so does that kind of answer? It's a very long-winded answer, but that one like really opened my eyes when you asked me that. And it was just a really cool discovery this week to like think back to that and find the heart of why I do what I do all over again.
Thank you so much for that answer. Yeah. That's beautiful. What part of midwifery itself really lights a fire in you now? Can you tell us a bit about that?
It's the people. I have no other answer except the people that I get to connect with. Like the team, the clients, the beauty, the relationship. It just makes it. It's like what makes the world go round to me is connecting with people and seeing their hearts and being in that space with them. And whether it's like finding out that they're newly pregnant, or hearing the heartbeat for the first time, or watching them become a mom and pull that baby up on their chest. Like every one of those connections is just like little nuggets of gold that I get to hold on to, that I get to witness, that nobody else gets. Like it's so cool. I get all of them all to myself. So I think the relationship piece for me is probably my favorite part of midwifery care.
Now, why do you think midwifery is needed in Bozeman when we have a hospital that offers prenatal care and labor and delivery services? So why midwifery?
The best way that I have come to be able to explain this is like, when I was younger and I was on this competitive volleyball team, and we would go every other weekend to compete in tournaments, and we would have to search for a hotel, right? All the hotels that you could find online, or Airbnbs, or wherever, you search for a place to stay, you can either choose like the budget option, which is great financially to do, or you can choose the 5-star hotel experience, right? So you know that when you choose a hotel that's nicer and it's higher in stars, you're going to get people that really care about you. You're going to get really comfortable rooms. You're going to get a great night's sleep because the beds are higher quality. Like both places are still going to give you a bed to sleep in and a parking spot, right? Like in the end. But then when you really dive into that experience, what do people pay for? They're going to pay for the comfort. They're going to pay for feeling lavish and important and cared for and tended and loved and all of those pieces, right? That's exactly the same thing. Like in the end, whether you choose midwifery care or birth center or hospital, it doesn't matter. Like you're going to get a baby out one way or the other. And we can never guarantee the outcome of a home birth. Like you're still going to get a baby, but it's the experience surrounding getting that baby out that makes midwifery care so different. And I really believe that like why we need it in Bozeman or anywhere is because women have the right to choose how they want their process to be. I don't think they should be forced into any one way or another. So I think we need it because women deserve to choose how they want to have their babies. Like that's the bottom answer. But in all reality, it's just a completely different experience. It's going to be like going in and having that 5-star dining experience, that concierge service at a hotel, those kinds of pieces. When you deal with a home birth midwife, they come to you. Like there's longer appointments. They care about your heart. They dive into your family. Like that's why we only see a few clients a month, because we dive in so deeply with you that we can tailor that care directly to who you and your family are. And so it's just a completely different experience.
Thank you. That really explains it well. And this is a really common question, fear. Can midwifery or home birth really be as safe as giving birth with a doctor in the hospital?
Yes. I think oftentimes women and families that don't search out home birth or search out any kind of out of hospital birth really look into the education that their midwives have. And so I think the safety aspect, when they're actually questioning safety, it comes from a place of unknown. Like they don't have answers as to what's actually keeping them safe. Because even in the hospital, like they can't guarantee life or death. They can't guarantee C-section or no C-section. They can't guarantee intervention or no intervention. Like they don't have a little crystal ball in the hospital either. And so honestly, I think that it comes down to a few pieces. I think number one, where the woman feels the safest is going to be, and be able to surrender, I guess, is going to be the place where she's more than likely going to birth the best that she can birth. And so as far as safety goes, I mean, all of the midwives in the valley we're licensed. Like we go to school, we're trained in emergencies, we know how to use the medications and all of that kind of stuff. So it's like we are trained and skilled the exact same way that the OBs are trained and skilled in the hospital. And so as far as the safety piece goes, I think a lot of people are like, safety wise, there's a C-section option available that's right there. And even though it has happened, like I have heard stories of where C-sections were needed right now and right away, usually babies give us warning signs. And so at home, like we're not just sitting there and waiting for an emergency to find us if it happens. We're actually listening to babies. We're doing vitals on mom. Like we're doing all of the medical stuff that they watch for in the hospital as well. We do it a little bit more keen with our ears so that we hear it sooner. So if there is a reason that our baby starts talking to us through their heartbeat and tells us that they need some further care or that they're not handling it well, then we can transfer in enough time to get to the hospital, because the hospital's still on our team. Like, they're part of every home birth midwifery team in the valley. It's just they've got the C-sections and they've got the epidurals that we need if we need them. If not, then we take really good care of our parents. So yes, I think that if a mom can surrender and have her baby in the comfort of her own home and she feels safest there and she can relax the most there, then absolutely. Like, there's no difference medically. Like, we're still trained professionals that take care of moms.
That was fantastic.
Okay.
I think so many people believe that midwives are still kind of this woo, alternative, weird thing that maybe isn't as safe, or a lot of people may not even know the difference between a doula who provides labor support and a midwife who is actually your medical care provider in that situation. So hearing you say that you have all the training, all the medical training of an OB, you just can't administer an epidural or do a C-section. Those are things that need to happen in the hospital, but otherwise,
Can I speak to something? As far as that goes, like, there's also this missing piece that most women don't think about. So when you go into a hospital and you're giving birth in a hospital, you come in, the nurses really, they do the IVs, they'll do the blood work for you, they'll come in and get you ready, and then you'll see the doctor for a few minutes, and then once that doctor has like done the vaginal exam and assessed you, they walk out again and they go to clinic, they go to all these other places. They're rarely in the room with you until the baby starts coming out again, or until assessment is needing to be done. The nurses are really the ones that are watching over you and tending to you in labor. And then the OB comes in and they deliver the baby, they suture if sutures are needed. And then once that's done and like placenta is out and they have sutured, they once again leave the room. And so nurses care for you postpartum. And then if anything happens with the baby, they've got a neonatal intensive care unit or the nursery that comes in and does the newborn exam and all of that kind of stuff. We do all of that. So we are the care for mom and baby from the time they start care with us through 6 weeks postpartum. So we do all of the blood draws and the tests and everything prenatally. We're going to see the moms the same as they would be seen up at the hospital. So every 4 weeks up until 28 weeks, we do the glucose visit at 28 weeks. We see them then every 2 weeks through 36 weeks, and then we see them weekly after that. So it's going to be the same care schedule. It's going to be the same tests offered. We offer the GBS test and all of that kind of stuff. So you're still getting the same base level of care and like testing that you could get done. But the difference is that you're seeing the same provider the whole time. So you're getting that continuity. So like, we know our clients inside and out. We know those babies inside and out. Like, their heartbeat becomes like a song to us in prenatals. And so if they start talking to us, we're going to know they don't sound like themselves and we can act quicker. And so then going into birth, we are there with them during active labor on. Like, we are listening to heart tones. We are doing the vitals. Like, that stuff is not missed. If there's something that's coming up, like, we see it because we're there the whole time. Our team is there the whole time. And then carrying into the postpartum, like if baby needs help or mom needs help, or we're just facilitating this beautiful postpartum journey, we're checking on both of them. So we're doing vitals for mom and baby postpartum. And then if anything is needed with baby or lactation or breastfeeding through 6 weeks, that's us. Unless either of them go outside of that normal boring umbrella, right? That's like safe for midwifery care. At that point, we assess and then we can move them to higher care if we need to. But most of the time, they're healthy. And so we are caring for mom and baby the whole time. So we love working with doulas. Doulas and midwives can work simultaneously together. And I often get the question, well, I'd like to use you. Do I need to hire an OB as well? Like, that's a very common question, actually. And I'm like, no, like, you don't have to do both unless there's a reason to have co-care in the picture. Like, midwives are the care providers here in the Gallatin Valley through 6 weeks postpartum. Like, we do everything that they would get in any kind of care clinic in a hospital.
I'll just speak really quickly to the co-care thing because that's something that I experienced with my second baby. I really wanted to have a birth center birth for my second baby because my first was in the hospital and it was a great birth. I showed up at the hospital pushing, had a baby, like next to no intervention. So the second time around, I was like, I got this. I tried to get my health insurance to cover a home birth. They wouldn't. I escalated it to like the highest level of appeal, and this was United Healthcare, and they said no like 3 times.
Most of them do.
Yeah.
It's not just United.
So I was like, all right, birth center. And then I did end up choosing co-care with my OB who had been at delivery for my first baby because my baby was breech. And I didn't know, well, I believed that he was flipping and changing positions all the time. And so I really wanted that birth center birth. But in the state where I was at the time, a midwife could not legally deliver a breech baby in the birth center. So I kept my OB kind of in my back pocket, stayed on as one of his patients, even though I think towards the end, I did start seeing him again for prenatal appointments, but then was also under the care of my midwife as well. And when the day came, I ended up needing an unplanned C section for multiple reasons. My baby was still breech, he was still high, he hadn't engaged, he had an extended head, I had almost no amniotic fluid left. Da 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 da. I was like, okay, this is the birth this baby needs. So I'm laying on the operating table, and all of a sudden there's a person at my shoulder, and it's a woman's voice, and she goes, "Hi, Maggie." And I look up, and it's my midwife who had privileges at the hospital, and I didn't even realize. So she assisted my obstetrician with my cesarean surgery, which was amazing.
Well, how did your heart feel about that? Like having your midwife, even though things didn't go as planned?
It felt incredible. It was a game changer because as much as I'd made peace with this is the birth that I need to have, the birth that my baby needs, I was still scared. I'd had so much surgery previously due to this car accident I was in when I was in my 20s. I was not looking forward to being cut open again. And I was scared, and hadn't just had an experience with my anesthesiologist where he had restrained my arms without telling me why, and I panicked a little bit, but luckily knew enough to advocate for myself. And I told him to let me go, don't tie me down. And he did. He was still a dick about it, but but he did. And so I had just gone through that experience, and then all of a sudden my midwife was right there with me, and she was an incredible woman. She was older, really had that sort of matriarchal, maternal, grandmother, like anchored kind of energy. And I was just like, oh, like it really is going to be okay because she's here. So can you talk, I know that you go with your moms if they transfer to hospital. So can you talk a little bit about that and what that experience is?
So we take 3 to 4 people on our team at every home birth in case there is a need for either mom and baby to both have a team if they need help postpartum or if we transfer. So one of my really big passion points is that they're my client's primary team, so it would be 2 of us, go with them to the hospital if they need to transfer. And so we stay with them. We have all of the records, all of the labs, all of the ultrasounds, everything like that ready to hand the hospital if we transfer. And then we stay there. So if a doula is with us as well, then we keep them on physical support for mom. And then we front all of the questions at the hospital. So when they walk in and mom is like getting her IV put in and we're making sure baby's on the monitor and safe, I am over at the computer with one of the nurses doing intake, all the lab questions, all of the ultrasound stuff, like everything that they need to know medically for her in order to get her safe and into a place where we need her to be. They don't have to worry about all of the medical stuff. Like the clients don't have to worry about the medical stuff. That's my job to go in and talk to the OB, to make a plan with them. You know, oftentimes depending on which hospital we go to, I'm even asked at some of the hospitals, like, what's our plan? Why are you here? What's going on? Like, how are we going to proceed with this? You know, or we can at least have a discussion with the OB as far as like, this is what's been going on. Here's her history. Here's who she is. This is what her desires are. So that's a big one. Like she's really naturally minded, doesn't want intervention, isn't interested necessarily in an epidural, but we're here for an epidural. And so I just want to tell you that's what's going on in her heart as we walk into this space. this is who she is. And we have found it to be incredibly peaceful with transfers because there is so much communication with the hospital. And we know, like, we don't go in with our boxing gloves up, like, hey, we're just going to fight it, right? We need something. We need help from them. We need further care, either mom or baby. One of them needs help. And so we go in, they respect us as care providers, we respect them as care providers, even though things are done very differently, which makes the whole transition very smooth so that our clients don't think that they're being like blindsided or something, in the picture. Like, we can come back with care plans, we can talk about what it's going to look like. And then we stay there and advocate for mom as well. So, like, if they're wanting some kind of intervention done and I can tell mom doesn't feel good about that, then I can help foster that discussion between the care provider and be like, hey, can you give us a little more information? Or can you let us know the why behind why you want to do this? Or how would this change if we decided not to do this? If we declined it, what would that look like? And so it's more of a fostering a relationship with another part of your team that you just haven't met yet. But we have done the fostering behind the scenes to make it a really smooth transition for mom.
A lot of people maybe who choose midwifery care are actually really afraid of the hospital. And so, in a situation where a transfer is required, that must make a world of difference into their level of anxiety and fear walking into the hospital, knowing that you're there with them and there to sort of help them navigate this whole transition.
Oftentimes, I think that people feel if we transfer from a home birth that they just have to say goodbye to their midwifery team. And so I just kind of want to combat that fear a little bit and say, we don't leave you. We never leave your side as your midwife. Like, we're still there as your midwife. We just don't have the privileges of being able to like work in C-sections and that kind of stuff. But that doesn't mean that we leave you as your midwife. And so I can't ever guarantee a vaginal birth. I can't guarantee, an alive baby. I can't guarantee any of that, but we do our darn tootiness best to get you everything that you want. And most of the time, it's like being empowered to make decisions for yourself or being autonomous and being given the options that are in front of you and not being blindsided. And so, as your midwife, like, I stick right beside you, whatever that birth looks like, even if it's the worst case scenario of a C section, and I've really this past year shifted my mindset that worst case scenario is a C section isn't how I view it anymore, because sometimes that means we get a baby that's alive in our arms. And so I'm like, even a C-section, I don't see those as bad. Like, I have really had some shift over the last few years as a midwife. And I'm like, C-sections are a gift when they're needed. They're a huge gift when they're needed. And so then I can come along my clients and I can say, okay, so how can we still make this empowering? Even if we had to have a C-section, how can we set you up postpartum and come in and care for you in your home and like swoop you back up postpartum? Because that's what we do. So we still care for them postpartum when they get home. So we take them from the hospital, we scoop them back under our wings, and we still care for mom and baby through 6 weeks postpartum. So they're not losing their midwife. We just have brought in another aspect of their care team because we needed them in the picture for this one. And we're still their midwives.
I think this speaks to my next question. What's the biggest challenge or issue facing expecting families in the Gallatin Valley today?
The thing that I hear the most about as far as challenges is financial for everybody. So, I mean, midwifery care costs for sure. I would say it's like most people's deductible, if not a little bit more, that they are mostly paying out of pocket. A lot of the midwives in the valley do run things through insurance, which is a big deal. But I think that's what I hear the most about is, let's say we have a cash pay mom or a Medicaid mom or somebody that's working 2 jobs and mom has to take a break while she's pregnant or something like that. I would say the financial tug and pull is probably one of the biggest hurdles that I see in the Gallatin Valley. And that's probably due to the fact that there's a lot of like an increase in cost of living here. There's an imbalance, I guess is what I would call it. I don't feel like normal people, like the normal working class here in the Gallatin Valley, has it very easy at all. Like, I feel like a lot of people feel stuck financially. And so there are definitely resources, that are out there and available. I know for our practice, we offer in-house financing for a lot of people. We will run any insurance except Medicaid. We don't do Medicaid. We'll offer any insurance billing that we can through our biller. So we actually have somebody that specializes to get you the most back that we can out of insurance. And then we also do care credit. So if you can't just like pay in cash in full, that doesn't mean that you can't consider out of hospital birth. Like every midwife in the area has a lot of different options for payment plans and stuff to make it totally feasible for people. And anyway, the care credit option that we offer, they can go up to 5 years to pay for it. So I would say even with the financing ins and outs of what it is, people will still pay $200 to $300. It's like a car payment, which makes it totally doable for a lot of families. And so I don't want them to feel like it's out of the question for them. Like, just talk to your midwives. We're nice people. We're really nice people. And we want you to have a home birth too, if that's where your heart is. So even though that's the biggest hurdle, there's ways to overcome it.
It's really great to know. And I think what a lot of people lose sight of too is even with insurance, you still have to pay your deductible. You still have this big out of pocket expense at some point. And paying for midwifery care gives you so much more than what you get in a medical setting where you go to your prenatals, but then you're kind of on your own for the rest of it, whereas you really provide support in addition to helping mom deliver her baby. I think you've already answered this question. What about your care makes working with you as an expecting parent extra special? I think we know now. So, like, wow, amazing. On a more serious note, what is the most serious complication you've dealt with during a birth, and how did you handle it?
So I think oftentimes when we are asked that specific question, because we get asked that question a lot, I don't actually think we're being asked that question. I think we're being asked, how do you keep us safe? Because even in the hospital, I don't care whether it's meconium aspiration or a shoulder dystocia or hemorrhage or it doesn't really, high blood pressure. Let's just like talk about all of them. I've faced all of them in birth. Like any complication that you can pretty much have, I have faced just about all of them. But as midwives, like we are there, going back to like the safety aspect, like we are there to care for normal, healthy, pregnant women. I call them boring in my camp. I love boring, healthy women. They're fantastic. And boring, healthy babies. They're fantastic in my camp. So that is the umbrella of families that we serve, is normal, healthy, boring families in such an endearing way. Please don't take me wrong in that regard, but they're wonderful. So our job as midwives is we are trained to not only stabilize, but we're trained to assess and stabilize moms if something starts going a little bit out of normal. So let's say that normal boring umbrella, we start to like dip our toe out of the umbrella into the abnormal realm. Or some kind of complication starts to happen. So what we do, that's why we bring all the stuff with us, is we are trained to assess and stabilize and either bring those families or that mom or that baby back under that normal boring umbrella, or we're trained to assess and stabilize and move to higher care if we need it. Like that's our whole job as midwives, and we're trained to do that. So we are trained to deal with shoulder dystocias and help get babies unstuck. We are trained to deal with hemorrhage and do fluid replacement and all of those kind of things, and to keep parents safe. Like again, I said the only things we really don't have are an epidural and a C-section. So we carry IV supplies with us. We carry all the same hemorrhage meds that the hospital carries in our bags. Like we have all of them with us. We can do catheters if we need to. We have all of the things to do mom and baby vitals. We are all trained in NRP and CPR. And so if baby needs oxygen or mom needs oxygen or something like that happens, we have all of those pieces in place. We can suture. We carry lidocaine with us. So it's like our little Mary Poppins bag of magic that we come with, or 6 bags of magic that we come with. We look like little pack horses because everything that they store in the cabinets at a hospital, we just bring with us. And you don't have to travel to get to those things. We bring them to you. And so that would be my answer, is like, I mean, every birth is serious to me, even if it's normal and boring, because of the magnitude of what it is. It's like they all mean so much. And so I think the how do we keep us safe discussion, like we are trained to do shoulder dystocia and hemorrhage and suture and, like fluid replacement and all of those kind of things. And then if we can't stabilize and move them back under, then that's when we call in our other part of our team and take them to the hospital.
I think we've touched on, I'll put these next 2 questions together. I think you've already kind of covered it, so you can sort of be brief if you want. What's your policy on hospital transfers? And what happens once you get to the hospital? Should a transfer be necessary?
They're there if we need them. Like that's my view on it. I'm very thankful for them when we need them, whether it's the NICU team or the surgical staff or just an OB to help us. If we need something that's outside of our realm, then they're there to help us. They're willingly there to help us, and we have really good communication again. So my viewpoint is they're always on my team. I love that they're on my team because that's how I can keep my moms and babies really, really safe, is to have them on my team. And then when I get there, it looks a little bit different for everybody. So if we need an epidural and we're going in for some kind of rest or maternal exhaustion or something along those lines, then we usually go in pretty quick. We do the transfer, just like what I was saying earlier. So we do the transfer where we hand them labs and ultrasounds and your health history and all of your prenatal records and everything, so that transition is smooth as far as the medical history piece goes. And then we get mom blood draws and labs as soon as we can. So they usually will place an IV, get labs really quick. And then as far as the epidural goes, usually most moms will have an epidural within half an hour of transfer, maybe an hour, depending on whether there's an anesthesiologist in the hospital or not, and how many people are helping different clients out in the hospital. So that the epidural one is usually pretty quick. And then once mom is settled and in her realm, like we can either go and nap if she's just going to nap, or we stay there if pushing commences. So they will mandate that you continue pushing at Bozeman Deaconess if you go incomplete. So if for some reason we just can't get baby out, there won't be any rest. It will be an epidural, and then we'll continue pushing. So it just kind of depends on the mom and what we're needing. And then as far as C-section, most of the time they will bring us in past triage, so we don't have to go into triage. And then they'll assess mom in a room, and then they'll decide if baby is okay to continue laboring for a little while, and we're gonna watch baby on the monitor, or whether we're like, we haven't seen any change in mom in 4, 5, 6 hours, whatever it is, and baby's having some trouble getting out, and so we're not seeing any change. Like, we don't know why there would be a change here over where you guys were at home. And so then we usually will make a collective decision as far as whether a cesarean is necessary. And then there's the emergent cesarean, which is incredibly rare to have, but it does happen. So if it were to ever happen, the baby wasn't doing great, cesarean's inevitable, and it's better to just get them in and get baby out safely. Then they usually will bring us past triage straight into the OR, and they'll put mom under and go in for a cesarean. So it kind of depends on what is needed as far as that goes, but we try to make it as peaceful as possible in every situation.
I know there's like a million different situations why you might decide to transfer to the hospital. Is there one reason that maybe is more common than others where you would say, okay, we need to go to the hospital now?
I think baby's heart rate is probably the one that I would transfer the most. Like if baby's having any kind of late decels, which tells us that they're not getting the nutrients and stuff that they need inside. So we're either seeing the variable decels where we know that there's cord involvement or some kind of lack of communication, or we've got the late decels, which they're a little more serious when we see late decels, that baby's not doing as great as they could inside. Those are probably the quicker transfers that we have if all of a sudden baby's heart rate is plummeting and we don't just have a baby flying out. That's probably the number one reason that we transfer for medical things that we find in the birth space. The other one is first-time moms. I would say we do transfer quite a bit for exhaustion. So if moms don't actually take it seriously when we say sleep and rest, like when you're in easy labor and early labor, please sleep if you can. Like lay down if you can. I don't need you sitting on a yoga ball at 1 centimeter and like working towards having this baby. Like I need you on your side, sleeping and ignoring it as long as you possibly can. Because once we hit 6 to 7 centimeters, if we've used up all of our energy reserves in the first part of labor, then the hardest part, it's the quickest, but it's the hardest part, and it calls most on mom. So that second part, if we've used all of our reserves up, we don't have anything else to pull from. And so we're kind of trying to grasp at straws. So I would say either maternal exhaustion piece, or fetal heart rate, which no one can control. Like that's why we listen to babies, because we don't know when there's going to be something wonky and hung up in there that we don't know about. That's why it's the secret place.
Just talking about heart rate. This wasn't on my list of questions, but I would love your take on it. Um, at the hospital here, they don't offer intermittent auscultation, so intermittent monitoring. Once you arrive, you're on a monitor consistently through the entire time that you're there. When somebody is laboring with you, you do intermittent monitoring or auscultation. You listen every 30 to 40 minutes. Is that okay? Yeah, I would love to hear you talk about what you do in terms of listening to the baby.
Even though the way that we're listening to babies is different, what we're listening for is the same. So it looks, again, same thing, looks a little bit different. So as far as like the early labor piece goes, we usually let moms labor on their own in the early part of labor. Once active labor hits, that's when we're listening really close. So in active labor, we're listening about every 30 minutes to baby. And when our team gets there, we do a baseline listen of at least 10 minutes. So it's 10 to 15 minutes. We are holding a Doppler on you for 10 to 15 minutes. And we are watching what that baby's heart rate is doing in response to those contractions. So we want a good long stretch to figure out what that baseline is. And that's just the medical definition. You have to listen over a certain period of time to be able to establish a baseline. And then once we've established that baseline for that baby's heart rate, then we know that if we hear any kind of decels or variability or anything like that, we know what the baby's saying to us. If we don't listen long enough, we don't know what they're saying to us. And so we listen for a 10-minute stretch when we get there. We listen for half an hour during that active labor time. Once we hit the phase that mom is pushing, then we listen way more frequently. So it's like once she gets to that last part of active into transition, we're upping that to every 15 minutes. And then when she starts actively like really grunting, pushing, feeling that urge to push, we're listening about every other contraction. And we're not just listening for like 2 to 3 seconds. Like our team is actually listening through a contraction. So we will come in, we will, wherever you are, we'll like get down on your level in the birth tub. We'll put the heart rate monitor on baby. We want to listen before, during, and after that contraction to tell us whether we're having any kind of accelerations, which are really good, whether we're just at that baseline that we were talking about with good variability, whether we're having some cord involvement, which tells us a lot. So we're going to see those variables, or whether we have a late decel in the picture that we need to listen to closer. Because babies are really resilient, but they're only really resilient for a certain amount of time. So you got to catch them in that time and listen close.
In a midwifery setting as well, knowing that maybe baby is like squashing their own cord or something, you would employ like, let's get mom to move and change position, see if baby changes position and gets off that cord, and does the heart rate improve? And then if it doesn't, then okay, we've got a more serious issue here. Let's go get some medical help.
That's not listening closely.
Yeah. Do you listen for like a 20-minute, what they call a strip in the hospital?
We do the 10.
A 10,
so
okay.
We do 10 to 15-minute strip. Get a baseline.
Great.
At least 10 minutes.
Okay, 10 to 15-minute strip. And then every 30 minutes, and then you up it to every 15 minutes during transition, and then every other contraction during pushing. And do you listen more often during pushing because that's just more stressful on the baby, that period of labor?
We just want to make sure the baby's coming back up. And we can also hear head compression. So it tells us where baby is without actually doing vaginal exams. So if you actually do your due diligence listening, and mind you, after that 10-minute stretch, unless there's a reason to get a new baseline, it's only about a minute that we're listening. So we're not like 10 minutes every half an hour. Like that's a lot, unless it's indicated. But anyway, so near the end, it's really cool because you can actually hear baby's head compression. So at the end of labor, when baby actually drops down and is like laying on that pelvic floor and mom's really having that good urge to push, or she's feeling a lot more pressure, you will hear that in the contractions. And so when you're listening to that heart rate and all of a sudden you have a contraction, baby will dip with the contraction, and that's a good dip. So those are the ones you hear, they're called early decels. So those are the ones that you're dipping with your contraction, and then as the contraction eases up, that heart rate comes back up. And I'm like, ooh, bet you're feeling a lot of pressure with that one. And she's like, yeah. And that's because that head is getting squished. It's a really good response. So it's showing us that baby is getting that head squished. They are responding to that. And then once the head is released, they just come right back up to themselves. So like that is a good dip to hear in the heart rate. So like we don't want parents to be nervous about hearing any kind of dips, but that's why we listen. It gives us a lot of information without having to do like regular vaginal exams and disrupt mom at the end.
As a midwife, last question, pretty much. This has been an amazing interview. What's your policy on cervical checks? I would love to know what you have to say about that.
I hate the word policy. Anyway, I'm just kidding. I'll actually answer. Okay. So prenatally, I know that often in facilities, moms start getting checked at like 36, 37 weeks, like when they're heading up to the point of delivery. All that really tells me is that they're X number dilated centimeters and they're not in labor. And so it gives me really invaluable information. Like I can tell just sitting here that a mom's not in labor, like I can just sit with her and say that and be pretty darn confident that she's not in labor. And that's pretty much what it gives me. And so if she wants a check in prenatal meetings, then she needs to ask me for it because I am not going to sit and just offer a check. So the only time that I really go in and do anything vaginally during prenatals is if we are at the very, very end and she wants or we need to do some kind of induction, natural induction. Then I will go in if she wants to and do a membrane stripping. But that is for the purposes of membrane stripping. We can gather all the numbers that we want to gather at that point, which tells us, it kind of gives us a baseline for her as far as where her body is. But I don't routinely do vaginal exams. And then for first time moms, I think that it's pretty helpful in labor to go in and get a baseline for mom when we get there. Because I feel like when we haven't done it before as moms, we don't really know where we are in our labor process. So unless she is really cranking and like super active and you can tell, I'll keep my hands off at that point. But if we're like, are we 5 centimeters? Are we 1 centimeter? Like there's no need for me to call in our whole team if we're 2 centimeters. And so if we can get a baseline that we know we're progressing normally as we go and we can check for those first time moms, that's a good time to check. It gives us valuable information. So I only do vaginal exams when it gives us valuable necessary information. So I would say that's one time that it gives us really valuable information. Another time is if for some reason we have a mom, and I don't care whether you've had babies or not, there's some labors where it's just doesn't seem right. Like it seems like there's something wrong. Like you would have expected to have a baby an hour ago when you got there, and then all of a sudden there's not a baby still. And you're like, huh, like I would have expected a baby at that point. And usually you're seeing some more indication in the labor, like a pain that's really weird or something like that. And at that point, I will look at my client and I'll say, do you mind if I just go see what's going on in there and see what's kind of got us hung up? Because I was expecting a baby a little while ago, and usually by that time, mom is very open to having something like that done. It's never done if she declines it, ever. Like there's nothing in my camp that I will do against her will. But most of the time, it's a valuable piece of information, again, that we can gather if we go in and just see what's going on. And most of the time, it's a cervical lip or something along those lines that if we can just resolve it, we can just have a baby. And it moves things along a lot quicker. So if it gives us a valuable piece of information, then I will offer and talk about it with my client. Then we can proceed with a vaginal exam. If it is ever declined or it won't give me any kind of valuable information, I will never do it unless she requests it.
I know cervical checks are typically done manually with fingers. Like this is like 3 centimeters, this is 10, which is crazy to me because people have different size hands, but that's a whole other discussion. Are vaginal exams or cervical checks ever visual?
I've had quite a few moms that are really empowered that have either had babies before or they're really in tune with their body. And so I will oftentimes, even if it's not for cervical dilation, I will often have my moms check themselves in labor. So if they're starting to feel pushy, we can have mom slide her finger in and during the contraction, feel how far baby's head comes down. And then when she pulls it out, I have her tell me where baby's head was. So as she's progressing, of course, she's going to be like, my whole finger was in. And then as she's feeling more pushy, she's going to be like, oh, I was only up to here. And then oh, baby's right there. And so I don't even need to put my hands in most of the time. Like if they are wanting that empowerment of feeling baby coming down and they want that information, then I empower them to do that themselves. And there are some of my moms during pregnancy that want to check themselves. And so I tell them how to do it. And I'm like, here's the chart. Like, here's what it looks like. And so they can reach in, feel their own cervix, their partner, husband, whoever's with them, like wash their hands. They can feel their own cervix. Like, as long as you do it clean, there's no reason that you can't be empowered to know your own body.
Final question. Yeah. What is your favorite thing about being a midwife in Bozeman?
Oh, can I give you two? Yeah. Because I feel like one is like, I've already said it. I love the people here. I love my crunchy moms. I love my empowered moms. I love my moms that like to get out and hike and Like they are just heart of my heart. I love people making me sourdough bread and bringing me chicken eggs. Like it makes me so happy. And like there are people that bring me like they get an elk and they bring me like a roast and our whole family gets to enjoy it. Like the heart of the people in Bozeman blesses my socks off. And I would say the other favorite part that I have is home visits here in Bozeman. Like I am never not blessed to the richness and fullness driving out to Paradise Valley or Dillon or Whitehall or Great Falls or Livingston. Like I am blessed all the time being able to sit in my car and live for me a dream and getting to go out and sit in somebody's home and hear their heart. Like
I can relate just with the people who come and see me in this space and work with me throughout pregnancy and into postpartum. Like it lights my soul on fire. Like there is nothing better. So thank you again so much for being here. Thank you for answering my slew of questions. And is there anything else that you'd like to say that you want people to know? Okay. Thanks again, and we'll definitely have you back.